Thank you and good afternoon for all. Yeah, it's a bit of a difficult topic for me because of two things, I think. One is how much we investigate dry eye. Ultimately, we treat with tears, nothing else. So why we want to investigate that extent? Other thing is, more or less, most of the investigations are not available here in our clinical practice. So that is also not an interesting thing. But anyway, I tried to catch up with few things. Before I go into the topic, just to highlight on anatomy, tear film has three main components, lipid layer, aqueous layer, and mucin layer. Lipid layer is secreted by the meibomian glands, and the aqueous layer is secreted by the lacrimal, major, and minor glands, and the mucin layer by the goblet cells. And when we talk about the investigations, before I go into that, I will just highlight about the definition of dry eye, or keratoconjunctivitis, which is a multifactorial disease of the ocular surface, of course, characterized by loss of homeostasis of the tear film, accompanied by ocular symptoms, and which causes tear film instability, hyposmolarity, and ocular surface inflammation and damage. And also, newer adding to the definition says that neurosensory abnormalities play an etiological role. This was given by the Tear Film and Ocular Surface Society Dry Eye Workshop 2017, which is well established and well recognized definition. I mean, it's involved more than 53 countries worldwide, this workshop in 2017, and they have given a good overall thing about dry eye and management as well as investigation. Before going into the diagnosis of dry eye disease, the history and examination is the key things. And our clinicians are very good in examining and diagnosing dry eye and start treatment. But on the other hand, why we want to do the investigations, we have to have the proper diagnosis as well as we need to grade the disease as well. When we consider about the investigations, there are about 6 investigation arms. First one is the dry eye symptom assessment questionnaires. Although it's a questionnaire or it's a history, it comes under the dry eye investigations as well. And it is a mandatory arm for dry eye diagnosis that we have to identify. And then the more conventional methods like tear film stability assessment test, volume assessment, ocular surface damage assessment, osmolarity, and ocular surface inflammation assessment test comes in. First, I will go through these questionnaires. There are many questionnaires has come up. One questionnaire which I want to highlight is ocular surface disease index. And other one is DEQ5 questionnaire, which is more recognized, but there are other questionnaires as well. When we consider about the ocular surface disease index questionnaire, it has 12 questions altogether asking about the dry eye history, whether during the last week you have sensitivity, grittiness, painful eyes, whether there's blurriness of vision, poor vision, and whether there's a difficulty in reading, driving, doing computer work, as well as watching TV, as well as whether you are uncomfortable in windy conditions, low humidity areas, as well as in air conditioning. According to this, they give a score. If the score is more than 13 or more, then you have dry eye disease. And other test, whereas T4's dry eye workshop recommend is the DEQ5, which also we have 5 questions and then give a score. And if it is more than 6, score is more than 6, then you consider patient is having dry eye. Then we go into more conventional test where we comes with tear stability. What we all know is a tear film breakup time, which also have 2 arms. One is fluorescent tear breakup time, and newer one is non-invasive tear breakup time. I will come into that later. And also we can do thermography, osmolarity variability, tear evaporation rate, and meibomian gland structure and functional assessment tests. There are a lot of tests regarding the tear stability. When we consider about the fluorescent breakup time or tear film breakup time, it's a quantitative test of tear film stability, which basically also about the meibomian gland function. Use a fluorescein strip which moistens with saline. That's why I want to highlight not with local anesthetic, it's moistens with saline. And then the tear film examine using broad beam slit lamp with a blue, cobalt blue filter. We have to ask the patient to blink 3 times before we start the test. That is the standard. And then the tear breakup time is the interval between the last blink and the appearance of the randomly distributed dry spot. Its sensitivity about 72 and specificity is less, about 61%. If the value is less than 5, which is abnormal, and 5 to 10 is considered suspicious, and more than 10 is normal. And drawbacks of this test is fluorescein itself reduces the stability of the tear film. That's the problem. Another thing is it's observer dependent as well. And people are now more going towards non-invasive tear film breakup time measurement, which is without fluorescein and is more preferable. And it uses the illuminated grid over the cornea, over the tear film, and the patterns are observed, and the image, when the image distortion starts, then we take as the breakup time. It has more sensitivity and specificity. We can use the keratometer, video keratoscope, corneal topography, and keratograph, which is the newest method, which is automated, observer not dependent, so it's more objective. And this is how the image is going to get distorted, and that time we take it as breakup time. And using the keratometer also, we can just use the keratometer mirrors and then detect the tear breakup time. And this is video keratography picture. Here, one thing I want to highlight is these values, non-invasive tear breakup time values, are longer than the fluorescein method. Usually the mean difference is about 3.7 seconds. So less than 10 seconds is identified as abnormal. And more than 20 seconds appears to be normal. And there is thermography as well, where thermography uses, like, once the tears start evaporating, the eye cools down. That's the theory behind it. More evaporation, less the temperature. So this is used by infrared thermography. This principle is used. It is a non-invasive method. Its specificity and sensitivity is high, it's around 80%. And there's a direct relationship between the fluorescent tear breakup time as well as the thermography. And this is a picture of the thermography. You can see at the bottom of the line, the redness is very much less. That means eye is cool. That means there is evaporation is more. And the top, there's a normal values are there. Then with the time, the evaporation, the eye cools down. And this is what assessment of thermography, and we don't have it here, I think. And then there's something called osmolarity variable. I will come into the how to check the osmolarity, but the osmolarity variability is measured between the two eyes. So if it is more than 8 millimoles per liter variable, then it's considered dry eye. And tear evaporation rate is also can be assessed, and I don't want to go into details about that. Then the meibomian gland structure and function assessment test are also available, which is more clinical and more available in our clinical setup. Meibomography, interferometry, and meibomian gland expressibility and duct assessment. When I talk about interferometry, you can assess the thickness of the lipid layer, which is about 40 nanometers, normal view, and lipid view interferometry is used as an automated way of measuring the thickness of the lipid layer. And although it's a more clinical assessment of the meibomian gland through the slit lamp, accessibility and the duct assessment is very important, and is also classified as an investigation. We have to check the eyelids, just press and see whether the ducts are open and easily accessible, the meibomian. And if the meibomian glands, meibomium is cloudy, opaque, or hyperviscous, then we all know if it is like toothpaste, then there's a problem with the meibomian glands, and this associated with dry eye. And meibomography is available in the private sector, which demonstrate the meibomian glands and the ducts. Initially, it was used the white light illumination. Now we use the infrared and with the infrared video camera. And it's nicely viewed the meibomian ducts. And we can assess the gland and the ducts. Then we can see the meibomian gland. Here, the top is a normal individual. And then going down, there is a damage to the meibomian glands. Right. Now, tear volume assessment test, the Shermer's test, meniscometry, and phenol red thread set also available. Shermer's is more popular test, which is quantified measurements of tear production. It's used as Shermer's strip. Patient instructed close the eye. Once we do the test, we place the Shermer's strip 1/3 of the inferior fornix, and we have to ask the patient to close the eye. Because if the patient has opened the eye, or if the eye movement occurs, then the test results going to be changed. And extent of wetting is measured at 5 minutes. There are two types of Shermer's. One is without anesthesia, that's type 1, and with anesthesia, type 2. Type 1 measures the basic and reflex tear secretion, which is usually, if it is less than 10 millimeters, abnormal. And with anesthesia, the type 2, it's only take the basic tear secretion is less than 6 millimeters is considered abnormal. Tear meniscography is also one method. We can use it the slit lamp method to identify the tear height, which is normal height is about 0.3 millimeters. But newer method of OCT meniscometry, which is a spectral domain OCT meniscometry, has a good inter-observer and inter-observer repeatability. So it's a non-invasive, and image acquisition is rapid and simple. So here you can see these OCT images. First one is a normal patient, and the second patient is, you can obviously, tear meniscus height is less and volume is less, and he's having dry eye. And phenol red thread test is a little bit of outdated at the moment, so I don't want to go into details. Now we assess the ocular surface damage. That's what happens with dry eye, right? You use ocular surface staining, then we can use impression cytology. Lid parallel conjunctival folds also can be assessed as ocular surface damage method. And in vivo confocal imaging also helps to find out the damage. Surface staining is used water-soluble dyes to detect the underlying pathology and the extent of the disease as well. Three main dyes that we use. One is fluorescein that we all know. Rose Bengal and Lissamine green is the other two methods. Fluorescein is stains only the dead and dying cells or missing epithelium. Compared to Rose Bengal and Lissamine green, both of them stains dying cells as well as unprotected cells. Unprotected means the mucus layer as well as the glycocalyx layer is absent. When there's absent, it stains. So it's good for conjunctiva, Rose Bengal and Lissamine green, compared to fluorescein. But Rose Bengal is painful, toxic, and irritant to the eye. But in Lissamine green is more like fluorescein, and most of the studies are using Lissamine green staining. Staining patterns, there are many patterns are there, but in dry eye, interpalpable and inferior staining is common, but if it's severe dry eye, which is a diffuse staining, we can observe. Lid viper epitheliopathy is a new term, I think, which is also very important, which is like two lids, upper and lower lids, act as a viper, and then this margin of the lids is rich of goblet cells and appears to be more sensitive tissue of the ocular surface. And staining of this tissue with fluorescein as well as rosamine green is identified as a diagnostic tool for determining dry eye. And there you can see minor changes, and here is obviously the lid margin is stained throughout, and it was assessed in the depth of the staining as well as the length of the staining. And tear film osmolarity also very important tool, and we don't have it. It's reported as a single best test of diagnosis and classification of dry eye disease. And if it is, we consider normal, it's less than 308 millimoles. Mild to moderate is 310 to 326. If it's more than 326, it's severe dry eye. And I don't want to go to the other test, but what I want to highlight here is how to diagnose And this is a take-home message, how to diagnose ultimately. According to the Tear Film and Ocular Surface Society Dry Eye Workshop 2017, one of the positive dry eye symptom questionnaires, that means DAQ5 score is more than 6 or ocular surface index score is more than 13. With that, if you have at least one positive results of a biomarker of damage to homeostasis of the tear film, that means tear breakup time, osmolarity, ocular surface staining. If one of these present, then you can diagnose the patient is having dry eye. So out of these, except the osmolarity test, other tests we have. We can get the questionnaire and fill up, as well as we can do the ocular surface staining with fluorescein or with non-invasive method. So we can diagnose in our clinical setup as well. Thank you.